All right, so let's go ahead and get started with malignant brain tumors. We will begin our agenda by reviewing the anatomy and physiology, then review signs and symptoms of brain cancer along with diagnostic workup. We'll review solid tumor rules, SSDIs, and staging, and then we'll review malignant brain cancer treatment and walk through a case example together. The brain is a complex yet essential organ of the human body, and it weighs approximately 3 pounds. The human brain is made up of many parts, each with a specific and important function. It controls our ability to balance, walk, talk, and eat. It coordinates and regulates our breathing, blood circulation, and heart rate. It is responsible for our ability to speak, to process and remember information, make decisions, and feel emotions. Every brain is unique, ever-changing, and extremely sensitive to its environment. The brain controls all 5 senses: sight, smell, touch, taste, and hearing. Since it controls these vital functions such as breathing, swallowing, digestive, eye movement, and heartbeat, there can be no life without it. The brain is divided into 2 hemispheres, right and left, and 3 main parts: the cerebrum, the cerebellum, and the brainstem. The cerebrum is the largest part of the brain. It performs higher functions like interpreting touch, vision, and hearing, as well as speech, reasoning, emotions, learning, and fine control of movement. The cerebellum, which is located under the cerebrum, its function is to coordinate muscle movements, maintain posture and balance. Brainstem the brainstem acts as a relay center connecting the cerebrum and the cerebellum to the spinal cord. It performs many automatic functions such as breathing, heart rate, body temperature, wake and sleep cycles, digestion, sneezing, coughing, vomiting, and swallowing. Now, within each hemisphere of the cerebrum, there are 4 lobes. Each lobe may be divided once again into areas that serve very specific functions. First is the frontal lobe that controls reasoning, judgment inhibition, mood, attention, some body movement, as well as bladder and bowel control. If there is damage to the frontal lobes, it can affect a person's sense of consequences and notions of good and bad. If you can imagine, that can result in reckless behavior. Next is the parietal lobe. This is located in the upper center, and it processes sensory information such as controlling reading, writing, and math. The occipital lobe is located at the back, and it controls the vision. And the temporal lobe is located at the lower part of the cerebrum, and it controls the hearing-related activity and long-term memory. Here's a fun fact: while most people use the left temporal lobe for language, there is a 5% part of the population that uses the right temporal lobe. It's important to understand that each lobe of the brain does not function alone, though. They are very complex relationships between the lobes of the brain and between the right and left hemispheres. In cancer coding, the tumors of the brain are often located in these sites or cross over from one lobe to the other. The brain has a folded appearance. By folding the cortex, the brain's surface area increased, allowing more neurons to fit inside the skull. Gray matter contains nerve bodies, which help to control muscles and sensory perception. The white matter contains long nerve fibers or axons and gets its color from myelin sheaths covering the nerves, and the white matter makes up half of the human brain. Multiple structures lie within the brain that aren't visible from the outside, such as the pituitary gland, the craniopharyngeal duct, and the pineal gland. So as abstractors, it's important to know that these structures are not considered part of the lobes of the brain, but have their own site codes. For example, the pituitary gland is coded to C75.1. So next, ventricles are fluid-filled cavities within the brain. The fluid is the cerebrospinal fluid. A ribbon-like structure, the choroid plexus, produces the cerebrospinal fluid. The cerebrospinal fluid flows within the brain and spinal cord and acts as a cushion. The cerebrospinal fluid is constantly being reabsorbed and replenished. There are 4 ventricles within the brain, the lateral, which are 1 and 2. They connect to the 3rd ventricle. The 3rd ventricle connects to the 4th ventricle. From the 4th ventricle, the fluid drains into 2 places, central spinal canal, and that bathes the spinal cord, and the subarachnoid cisterns, and that bathes the brain. Between the arachnoid matter and the pia matter. So here is a diagram. The cerebral spinal fluid is being reabsorbed back into the circulation. Also, a vital part of the brain is the nervous system. The central nervous system, or CNS, controls the brain and spinal cord, and the PNS, or peripheral nervous system. That's divided into the subatomic and the autonomic nervous system that controls the nerves of the spinal cord and cranial nerves. The autonomic nervous system is involuntary control of internal organs, blood vessels, smooth and cardiac muscles. The somatomic nervous has voluntary control of the skin, bones, joints, and skeletal muscle. The 2 systems function together by way of nerves from the PNS entering and becoming part of the CNS, and vice versa. So next is risk factors. Unlike other forms of cancer, which are often associated with lifestyle activities such as smoking, dietary factors, or drinking, there is little known about why brain cancer occurs. One is an environmental factor, a chemical used in making plastics called vinyl chloride. If someone lived near a plant that used or disposed of vinyl chloride, there is a chance it leaked into the water supply, but studies show that most brain cancers do not have this exposure. Genetic mutations, or changes in the genes reproducing cells in an uncontrolled manner, is the result of most brain cancer. However, some forms of brain cancer are known to be inherited. Also, age is a risk factor because while brain tumors can happen at any age, it is more common overall for the person to be an older adult. There are only certain brain tumors that happen most often in children. Race can affect the risk because gliomas are most common in white people and meningiomas are more common in Black people. People who have a strong exposure to radiation also have an increased risk, and inherited syndromes such as neurofibromatosis or Lynch syndrome can change the DNA, which increases the risk as well. Next is signs and symptoms. Different parts of the brain control different functions, so brain tumor symptoms will vary depending on the tumor's location. For example, a brain tumor located in the cerebellum at the back of the head may cause trouble with movement, walking, balance, and coordination. If the tumor affects the optic pathway, which is responsible for sight, vision changes may occur. The tumor size and how fast it's growing can also affect symptoms. that the person will experience, genetic predisposition or family history of brain cancers or personal history of brain tumor, or exposure of radiation in an environmental setting can increase your chances of brain cancer. In general, the most common symptoms of a brain tumor may include headache, seizures, convulsions, difficulty breathing, speaking or finding words, personality or behavior changes, weakness or paralysis, loss of balance, loss of hearing, vision changes, confusion, and memory loss. Many times, these signs and symptoms are reported at or prior to diagnosis. Incorporating this information into your exam text, or H&P text, is recommended. So let's take a look at the diagnostic workup related to brain cancers. Doctors use many tests to find or diagnose a brain tumor and learn the type of brain tumor. They also do tests to find out if it has spread to another part of the body from where it started or metastasized. It is rare for a primary brain tumor to metastasize. Doctors may also do tests to learn which treatments could work best. So we have the MRI brain, the CT, the PET scan, the cerebral arteriogram. These are used to visualize the tumor, check the size, extent of disease, and check for regional or distant mets. A biopsy or removal of part or all of the tumor with surgery may be performed. So in a biopsy, the doctor takes a small sample of tissue for testing in a laboratory. But if this is not possible, the doctor may suggest other tests to help make a diagnosis. Biomarker testing. So on the tumor sample for genetic mutations, proteins, and other factors unique to specific types of tumors, AKA is called molecular testing. So for example, a glioblastoma may have MGMT that's commonly done. A patient with an increased MGMT is more likely to respond to alkylating agents, and that is effective for brain tumors. So here are some quick tips. The stereotactic biopsy is a brain tumor that is coded to surgical code A200 or 2023, not diagnostic and staging procedure code 02. So by definition, a stereotactic biopsy is a surgical procedure where a thin needle is inserted into the brain by a neurosurgeon to extract a small piece of tissue to examine under a microscope. The procedure is done in an operating room. A craniotomy is performed, the burrow hole to the skull to gain access to the brain tumor, and a biopsy is performed. Usually, the MRI imaging confirms the location of the tumor prior to the procedure. So if we have this, we record the findings and the procedure info into the operative text, and we include the technique, such as stereotactic, if it's performed. Another tip for clinical grade, review the imaging or biopsy, not the resection of the tumor. The histology may be listed in the WHO grading table in AJCC 8th edition. For example, a patient's MRI states consistent with glioblastoma, but no biopsy is performed. The clinical grade based on the clinical diagnosis is 4, the WHO grade 4, on AJCC 8th edition, Chapter 72, Table 72.2. Glioma is often described as high grade or low grade, so we use the proper grade of H or L if no further clinical impression is given. However, if no grade is given, then we would use 9, and that would be appropriate. Glioblastoma is not listed on the table 72.2. Next, we have NCCN guidelines. These are available for CNS cancers. The link to the document is on the current slide. Registration for the website is required, but it is free. prior to viewing the document, we would have to log in. Treatment for brain cancers usually involve resection and some form of adjuvant, radiation, chemo, or a combination of both. Often, if the biomarkers are involved, such as MGMT or methylation, the treatment can vary. Guidelines can also vary by histology, so adult glioma includes glioblastoma, astrocytoma, and oglodendroglioma, adult medulloblastoma, and adult intracranial ependymoma. So on the screen, here's an example of a treatment pathway for glioblastoma. If the patient is older than 70 years at diagnosis, they have a good KPS score greater than 60, and their tumor is methylated versus unmethylated, the treatment standards can vary. For methylated, they may be put on a clinical trial or receive radiation and chemo, but if their performance status is less than 60, they may be limited to just radiation or chemo and no clinical trial. Also available is the NCRA informational abstract for the malignant brain. The link is on the current slide. This is an outline created by NCRA to assist in determining what text to include. The outline has a specific sequence designated to maximize efficiency and includes 8 sections. So we have physical exam/history, x-rays and scopes and scans, and then we have labs, diagnostic procedures, pathology, primary site, histology, and treatment. It is free and it can be very helpful. You can see from the examples on the slide that the imaging tests in the diagnostic procedures are recorded with the most pertinent findings. You will need to download the most recently updated document, but Brain is on page 40 of the document. So let's move on to Solid Tumor Rules. Malignant CNS and peripheral nerves does have its own chapter in the Solid Tumor Rules. Here's a couple things to remember. These rules apply only to behavior/3 code, invasive malignant brain. We do have a priority order for behavior. First, we'd have the pathology, that's pretty standard, and cytology, physician's documentation of the tumor board documentation, something like that. And then we also have an imaging priority order, and not every manual has this in the Solid Tumor Rules. Module, not every module has it. So we have the MRI would come first, and then the CT, the PET scan, and the angiogram. We have the WHO grade table that's also listed in the set of rules. That is in Section 1, Table 1. And we use this if no other information is available. We have a primary site that must be reportable list. And then we have the polycytic astrocytoma/juvenile pilocytic astrocytoma for 2023 and forward. This is going to be a 9421/1. If you're still working on 2022 and prior cases, and many people can be, then these are /3 behavior unless the primary site is optic glioma or optic nerve, which in this case would be a /1 non-malignant. We also have a listing of paired sites on Table 5. For that list, laterality must be coded for those sites. However, SEER does allow laterality to be coded for others available, but it's not required unless the sites are in that table. And then we start at the first rule for the section, either the multiple primary rules or the histology rules, and then we stop at the first to apply. Some items to take note of in the Solid Tumor Rules are the 2018 Solid Tumor Rules change for glioblastoma multiforme. So 2007, the MPH rules said same or single tumor, single primary if GBM followed astrocytoma or glial tumor. And 2018 forward, the glioblastoma multiforme is subsequent to an astrocytic or glial tumor is a multiple primary. And this change happened because the glioblastoma multiforme can be analyzed for the frequency in which these tumors occur in a more aggressive form. Here's some clarifications. The multiple brain tumors of the same histology are single primary. Tumor is not used to determine these multiple primaries. Oftentimes we do have a timing rule, but we do not have one here. The brain, C710 through C719, is a single primary site. Laterality is reported if listed in the paired sites, but C71.8 is not a paired site. But a left glioblastoma multiforme and a right glioblastoma multiforme is reported as one primary. Also, if a tumor is diagnosed before 2018 and a subsequent tumor diagnosed 2018 or later in the same primary site, then we use the 2018 Solid Tumor Rules, the more current rules. You can download a copy of the most recent Solid Tumor Manual. So it is 2023, but it's the update of 2018. And that is at the link at the bottom of the slide. So let's try using these rules in an example and follow along as we work through the case. So here is our brain case example. We have a physical exam with a patient that presents with migraines and blurry vision, intermittent nausea and vomiting. The patient fell recently, hit her head, did not lose consciousness. The CT of the head showed a 2 centimeter midline shaft to the right mass in the left frontal lobe. Could be a hematoma from a fall, but mass is possible. The MRI brain showed a 2.7 centimeter mass in the left frontal lobe, suspicious for glioblastoma. No other masses identified. The operative report, the stereotactic biopsy of the left frontal lesion. This showed a large tumor at frontal lobe, entire tumor removed in multiple sections, no residual tumor verified with imaging, and that pathology showed the left frontal lobe of biopsy. The tumor is in multiple pieces, but the largest size was 1.2 centimeters, glioblastoma multiforme, WHO grade 4. So, from the looks of it, this is a single tumor. When we look at what multiple primary rule applies, we would start in the single tumor section of the multiple primary rules. Rule M2 is the first rule available and the first to apply. Abstract the single primary when there is a single tumor. And then let's talk about what histology rule applies. Let's skip now to the histology rules. Since we have a single tumor, we can start in that section. H1 is the first rule. It refers to CNS tumors for neurofibromatosis, and our histology is glioblastoma multiforme. So what would the second H2 rule be? That refers to meningioma, and again, that's not our histology. The next rule is H3. It states to code only one histology when one is present, and that is the first rule to apply, as we only have one histology noted by the pathologist. So H3 would be our histology rule. This one was easy. The imaging indicates a glioblastoma clinically. The pathology indicates a glioblastoma microscopically. So let's see if we can answer a few more questions based on this same case. What is the clinical grade? Glioblastoma is mentioned in the imaging, so we can verify the clinical WHO grade by checking Table 1 in the Solid Tumor Rules in the Malignant CNS chapter. What is the pathologic grade? Glioblastoma multiforme is mentioned in the pathology report. So we ask ourselves, is that the same as glioblastoma? Is there a different grade? What is the histology code? So we would go to Table 1 and Table 3 in the Solid Tumor Rules, and we have it here. Was the stereotactic biopsy a diagnostic procedure or surgery? This would be found in the Appendix C surgery codes of the STOR manual. And then we have a bonus question. What is the primary site code assigned? So first, what is the clinical grade? That would be a 4. Who grade for glioblastoma on MRI? Remember the table in the AJCC or the Solid Tumor Rules indicate glioblastoma has a clinical grade of 4. What is the pathologic grade? That would be a 4. Who grade 4, the path was glioblastoma multiforme on the stereotactic biopsy. The grade was provided by the pathologist as grade 4. What is the histology code? 9440/3 glioblastoma NOS is 9440 synonyms per the Solid Tumor Rules include glioblastoma multiforme. This is not a subtype, just another name for glioblastoma. Also, if you look there, the synonyms include the glioblastoma multiforme, the glioblastoma IDH wild type, and epithelioid glioblastoma. Was the stereotactic biopsy a diagnostic procedure or a surgery? Code A300, gross resection of tumor, would be our code. This was a gross resection per the operative text. The intent was to biopsy the tumor, but per the operative report, showed the entire tumor was removed. We only need to show the most extensive procedure, even if there was a biopsy during the same procedure. So we would code the resection of the tumor. And then our bonus question. What is the primary site coded to? The left frontal lobe of the brain, C71.1. You would apply laterality here as the brain lobes are a paired organ. So next is treatment. Treatment for malignant brain cancers includes surgeries. The surgery STOR manual 2023 has the Appendix C for the surgery codes, and we have that available at the link on the slide for brain and spinal cord. Surgery includes removal of entire tumor or partial tumor. The surgery codes are A200 through A550. Those incorporate local excision of the tumor, complete removal of the tumor, and removal of partial or entire lobe of the brain that contained the tumor. Codes A300 through A550 specifically do not apply to spinal cord or spinal nerve primary sites, only brain. And then margins are not usually available in the pathology report unless stated by the pathologist, and that would be coded to 9 unknown. We also have radiation. Radiation is usually given adjuvantly after resection or alone if unresectable. External beam radiation is given to brain tumors, including stereotactic radiosurgery, gamma knife, cyberknife, or LINAC, which are types of external beam radiation therapy techniques. The link to the CTR guide to coding radiation therapy treatment in the STOR is available on the current slide. This document will provide help coding radiation treatment. This document is located now within the Appendix R of the STOR Manual 2023. But here is a chart for applicable planning techniques based on the type of radiation. So for example, gamma knife is coded to a modality of 02, and if gamma knife is administered, the planning technique is 08 stereotactic radiotherapy or radiosurgery gamma knife. There are also useful abbreviations for all types of radiation and a summary of radiation coding rules. For example, how to code no treatment or unknown modality. So we use this guide to view any examples of coding radiation for 2023 diagnosis years and forward. Systemic therapy can be reviewed on the CRRX website. So we look up the agents prior to entering them. This is a common practice for me to double check even if I think I remember the category, because we can't remember everything. So we have chemotherapy, and the most common chemotherapy is the Temodar. Then we have immunotherapy, and that would be Avastin, and clinical trials, so capecitabine and Temodar. I have hormone therapy in red here because the Decadron you will see, but is not considered treatment for brain cancer. It may also be referred to as dexamethasone, prednisone, and other names. So be sure to check the Anti-Neoplastic Database, or CRX, for reportability of these and other drugs. When we check the CRX site for Decadron, a helpful note is provided to state that it is not cancer-directed for brain and do not code. Coded as other forms of treatment is Optune, which uses electrical energy fields to treat brain tumor. Optune is coded to other treatment per the SEER Anti-Neoplastic Database. For many with advanced brain cancer diagnosis, no treatment or hospice is elected. Oftentimes, palliative chemo or radiation is completed to reduce the tumor burden on the patient, relieving symptoms without the intent to cure the cancer. This is coded in addition to the actual drug. If chemo with Temodar is administered for palliative reasons, you will code chemo and palliative separately. If chemo and radiation are administered palliatively, we can use a combination code of 5 or 6, depending on whether the patient was receiving pain management and or was referred to a pain management clinic for their cancer. The STOR manual provides instructions for palliative treatment. A common misconception is coding a hospice or comfort care referral to code 7 under palliative treatment. A referral to hospice is not coded as palliative care, so we should not use code 7. A referral to palliative medicine and no other information is available may be coded to 7. A referral to the pain management clinic is coded to a 4, as long as no other palliative treatment is administered. So switching gears, let's talk about the SSDIs for malignant brain. There are 4 SSDIs. So we have brain molecular markers, chromosome 1p, loss of heterozygosity, chromosome 19q, loss of heterozygosity, methylation of 06, which is the GMT. The first SSDI is new since 2018. The multiple brain molecular markers have become standard pathology components necessary for diagnosis. This data item captures clinically important brain cancer subtypes identified by molecular markers that are not distinguishable by ICD-03 codes. This SSDI only applies to histology codes listed. Remember, the histology codes also include NOS codes. Glioblastoma NOS 9440/3 is the same code as glioblastoma IDH wild type. This SSDI requires a specification of type of histology based on the molecular markers performed. Next, we have the loss of heterozygosity for chromosome 1p and 19q. These have normal cells that complete copies of each chromosome. The loss of chromosomes 1p and 19q aid in diagnosis to make treatment decisions. They are usually done at the same time. They are separate SSDIs. Next, we would go further into the chromosome 1p, loss of heterozygosity. This item used to be collected as site-specific factor 5, and it was converted to the SSDI in 2018. A normal cell will contain 2 copies of chromosome 1p, one from each parent. Loss of heterozygosity for chromosome 1p, only one chromosome identified, and then the second chromosome has been deleted. So if no deletion, then we code 0. If we have the second chromosome deleted, then we code 1. And if it was ordered, tests unavailable, we have a code 7 for that. But if it's completely unknown, then we have the code 9. So here's the loss of heterozygosity for 19q. This used to be the site-specific factor 6. A normal cell will contain 2 copies of chromosome 19q, one from each parent. And again, the loss of heterozygosity from chromosome 19q, only one chromosome identified and the second chromosome deleted. And our codes are the same as the last SSDI. Then we have the MGMT. This used to be collected as site-specific 4, and now it's the SSDI 2018. An enzyme in cells that repairs the DNA. Methylation of MGMT, gene-reduced production of MGMT enzyme, and the ability of tumor cells to repair damage caused by chemotherapy. It is a prognostic and predictive factor for high-grade gliomas. And then if there's an increased MGMT, it is more likely to respond to alkylating agents like temodar and lomustine. So we have certain codes here. If it's not detected or unmethylated, we have a code 0. If it is detected at a low level or hypomethylated or partially methylated, it is a code 1. A high level or hypermethylated would be a code 2. If we know that it was identified, but we don't know if it's high or low, it's not showing any of those terms, we have a code 3 for that. And then the standard 7 if we know it was ordered, but no results or physician statement of the results. And unknown completely would be a code 9. So staging for malignant brain for AJCC. There is no staging for the brain. The tumor size is significantly less relevant than tumor histology and the location of the tumor. So the T category is less important than the inherent biologic nature of the tumor. So because the brain and spinal cord have no lymphatic system, the N category does not apply, as there are no lymph nodes to identify or count. And then an M category is not pertinent to most CNS neoplasms because of the inherent biology that favors local recurrence and regional spread. As we mentioned, it rarely metastasizes. But a quick tip, the new AJCC 9th edition for brain and spinal cord tumors apply for cases diagnosed 1/1/2003 and forward. Medulloblastoma staging only consists of assignment of the M category. So moving on with staging for malignant brain, we will focus on the brain for this presentation, define intratentorial versus supratentorial tumors, and the summary coding criteria for the brain. Here we have tentorium cerebelli. The tentorium cerebelli is an extension of the dura mater and separates the cerebellum from the inferior portion, roughly in line with the top of the ears. The brainstem passes through the tentorium. The tumor above the supratentorial or infratentorial, below the tentorium, can help determine the type of tumor. Most adult brain tumors are supratentorial, and most pediatric brain tumors are infratentorial. C71.0 through 9 include both infratentorial and supratentorial tumors. The following subsites are infratentorial, so all subsites for codes C71.6 through C71.7. Then we have the hypothalamus, the pallium, the posterior-cranial fossa, and the thalamus. The pallium and the thalamus have both C71.0 as well as the hypothalamus. And following subsites of the supratentorial, all subsite codes of C71.1 through C71.5. We have a primary site code of C71.0, and then a few different ones of the anterior cranial fossa, C71.9, the corpus callosum, the C71.8, the middle cranial fossa, C71.9, the tapetum, C71.8, and the suprasellar, C71.9. So next we have the CTR codes. Localized tumors are confined to the brain are coded to 1. Infratentorial tumors may be confined to the brainstem or meninges of brainstem on one side, the cerebellum or meninges of the cerebellum on one side or midline, or both the cerebellum or brainstem involved with tumor on one side. The supratentorial tumor is confined to the cerebral hemisphere or the meninges or cerebral hemisphere on one side. That includes the 4 lobes. There is no regional node staging for this site. Regional tumors by direct extension involve the bone, the corpus callosum, the major blood vessels, meninges, nerves, spinal cord/canal. Supratentorial tumors extend to the infratentorial to involve the brainstem, cerebellum, hypothalamus, pallium, the posterior cranial fossa, and the thalamus. And the infratentorial tumors extend supratentorially to involve the interior cranial fossa, the cerebrum, the corpus callosum, the middle cranial fossa, the suprasellar brain, the tapetum, and the tumor that crosses the midline. There is no regional node staging for this site. So code 7 includes the distant sites, such as nasal pharynx, posterior pharynx, nasal cavity, etc. Then we have the distant METS NOS code. And 9 is unknown and should be used sparingly. If imaging is available, then we usually can have the coding and it should be staged. We've arrived at our case scenario. We will use all of what we've reviewed together to assign codes for this case. So as we go through it, try to make a mental note of what the primary site, histology, date of diagnosis, grade, treatment, staging, and SSDIs should be. We have a 50-year-old female on the H&P presented with a sudden onset of intermittent left-sided numbness. The patient had a recent fall, a head injury with loss of consciousness, and reports head pain. The patient was initiated with dexamethasone on 9/18/22. And the CT head showed a 1.2 centimeter mass in right frontal parietal lobe. The MRI brain showed a 1.7 mass in the right frontal parietal lobe. No other lesions identified, and it was consistent with high-grade glioma. The post-op MRI brain showed post-operative changes of right frontoparietal lobe, no residual disease identified. On the labs, the MGMT was methylation present and low, 1P gene deletion, and 19Q no deletion. The operative report, a stereotactic biopsy of frontoparietal lobe mass. The path pass off for path review. The path confirmed astrocytoma. Decision was to remove the entire mass. The entire mass was removed in multiple pieces due to the size, and the intraoperative MRI confirmed no tumor remained. The pathology report showed astrocytoma Hu grade 3 in specimen A and an anaplastic astrocytoma IDH mutant Hu grade 3 in specimen B. The surgery was titled right frontoparietal craniotomy with removal of lesion, and the Temodar was initiated on 11/4/22, and the patient declined radiation therapy. So let's look at what we have here. Thinking about our case scenario, our primary site is going to be C71.8, overlapping lesion of the frontal and parietal lobes. The histology 9401/3 for anaplastic astrocytoma, IDH mutant. And the diagnosis date of 10/4/22 because the MRI brain stated consistent with high-grade glioma, and it is a laterality 0. It is not a paired site per the Solid Tumor Rules. The date of first treatment is 10/15/22 of the stereotactic biopsy with gross resection of tumor. And the surgery code is it's a 2022 case, so it is code 30, and it was a 30 because the surgery was removing the entire tumor per the operative report. 20 would not be coded if it was just the stereotactic biopsy. 20 would be coded if it was just the stereotactic biopsy that took place and the tumor was not grossly removed. Then we have chemo code 02. The Temodar was a single drug, so we used the 02 code. There was no hormone therapy. The dexamethasone was not coded. It's not coded as treatment to the brain per the CRX. And the clinical grade was stated to be a high-grade glioma, so that is going to be a code H. And the pathological grade is grade 3 per the 72.2 AJCC table, or the Solid Tumor Rules is Hu grade 3. Then we have a radiation code of 87 because the patient declined or refused the radiation. And the diagnostic and staging procedure is not going to be entered. The biopsy was done in the same procedure as the resection, so we code the most definitive procedure at the encounter. And SEER summary is going to be a code 1. The disease was not beyond the brain, and no extension to adjacent structures listed in the summary stage manual. So then we have our 4 SSDI codes. The brain molecular markers is going to be a 03 because it was microscopically identified as anaplastic astrocytoma, IDH mutant per pathology text. The SSDI, loss of heterozygosity, is going to be chromosome 1P. It's going to be coded as a 1 because 1P was deleted per the lab text. The SSDI LOH chromosome 19Q is going to be a 0 though, because 19Q was not deleted per the lab text. And then the MGMT is going to be a code 1 because it was detected and it's stated to be a low level. So in conclusion, we discussed the anatomy and physiology of the brain, the signs and symptoms of brain cancer, and the common diagnostic workup for brain cancers. We also discussed solid tumor rules, brain cancer treatments, SSDIs for malignant brain tumors, and reviewed the available staging for malignant brain cancers. Finally, we tested our knowledge with a case scenario. Here is an abbreviation slide for reference. And I thank you for joining us today. We're going to check if there are any questions.